Hello, my name is Paul Chicane. I'm an assistant professor of anesthesiology and pain management at Mount Sinai West Hospital, and I'll be talking about interventional pain management techniques for the geriatric population. I have no disclosures. So overall, we will discuss what the role of a pain management physician, especially an interventional pain management physician, is in the multidisciplinary treatment team. We'll go over some common causes of neck and low back pain, which are two of the more common chief complaints for primary care visits. We'll introduce our commonly performed procedures that we use to treat neck and low back pain. And then finally, we will review sympathetic nerve blocks for various visceral type pains or malignancy related pains. So what is a pain management physician? We are physicians with specialized training in evaluating, diagnosing, and treating different types of acute, chronic, or cancer pain. We can be referred to at any step of the process. Think of us almost as the primary care of pain. So oftentimes we have a primary certification in anesthesiology, but can come from other backgrounds such as physiatry, neurology, even psychiatry, emergency medicine, and internal medicine. And we are part of a multidisciplinary team, and like I said, can be involved at any step in the workup or treatment process. So as you are all aware, chronic pain does require multidisciplinary approach with a multimodal analgesic approach. So not only are medications helpful in the algorithm of treating chronic pain, but as you are aware, also rehabilitation with physical therapy and occupational therapy, interventional techniques such as injections, which is what I'll be talking about today, but also psychological intervention as well. So the answer for chronic pain is never one of these avenues, but usually a combination of these techniques to take care of the patient in chronic pain. So pain medications often come with intolerable side effects. And in the midst of the opioid epidemic, we realize the risk of addiction is high. So this is the importance of interventional pain management techniques to hopefully rely less on medication management and treat the pain more with the intervention. And oftentimes we can bridge the gap between pharmacological management and more invasive operations and surgeries. So often with our injection techniques, we're able to avoid more major surgeries. So when we're talking about low back pain and neck pain, I like to just go back to the anatomy. So when you're thinking about a patient whose chief complaint is low back pain, try to just go from skin all the way anterior to the vertebral columns and think about what can be causing the pain. And we're going to go over some common causes before we talk about the actual injections. So you can have spinal column pain, which comes from the spinal nerve roots, the facet joints, the discs themselves, or the vertebral bodies. More posterior to that, you can have muscular pain or ligament pain. And finally, you have pains that mimic spinal pain, and this could be the sacroiliac joint, abdominal or pelvic viscera, the pancreas, abdominal aortic aneurysms, and kidney stones. So your history is very important when you're working up neck and low back pain. So in somebody who is young, you're obviously going to have more of a incidence of myofascial pains or muscular pains. In older population, as we age, we have more degeneration with the discs and with the facet joints. You also have to keep in mind that their pain could be related to neoplasms, pathological fractures related to osteoporosis, infection, or some other life-threatening extraspinal process, like we mentioned before, abdominal aortic aneurysms. So when you're talking to your patient, you're going to want to differentiate if this is an axial, non-radiating pain, mainly at the low back, or does this radiate into the thigh, calf, foot, or any part of the leg. This will be the first step in helping guide the interventional technique. You're going to ask about history of trauma, which will make other diagnoses higher on your differential list. And you're going to always ask about constitutional symptoms, fevers, chills, night sweats, weight loss, to make sure the patient doesn't have an underlying neoplasm or infection. Finally, you're going to want to make sure the patient doesn't have any red flag symptoms that might indicate either Cauda-Equina syndrome or myelopathy. If a patient is also complaining of imbalance, clumsiness, weakness, this may be a sign of myelopathy. Or if a patient has the weakness, saddle anesthesia, and bladder bowel incontinence, this may be a sign of Cauda-Equina syndrome. So when we're talking about radicular pain, this is what is colloquially referred to as sciatica. We don't really use the term sciatica in interventional pain management. We like to refer to it as a radiculopathy, and this is a pain related to spinal nerve root, usually from a herniated disc. When we're talking about non-radiating or axial type pains, we're thinking about usually three things: the facet joints, the discs themselves, or the vertebral bodies. So talking about radicular pain, like I mentioned, related to usually compression and inflammation of the spinal nerve roots. And the most common causes are disc herniation, but also ligamentum flavum hypertrophy can impinge on the spinal nerve as well. The facet joints, as we get older, just like patient who has knee arthritis, can hypertrophy. And if you look on this figure here, there's not a lot of room for facet hypertrophy before you start impinging on the foramen where the nerve root is coming out. If a patient has congenital spinal stenosis, this also puts you at risk for lumbar radiculopathy, along with some other not as common pathologies, such as Tarlov cysts, arachnoiditis, infections, and neoplasms. All this can relate to radicular pain. So the patient will complain not only of back or neck pain, but also pain that is sharp shooting down an extremity. It could be associated with paresthesias and numbness in a dermatomal fashion, and may be related to subjective and or objective weakness and hyporeflexia on your exam. The extremity type pain may be unilateral or bilateral, depending on which nerve root is impinged. So lumbar radiculopathy, lumbar radiculopathy most commonly involves the lower lumbar nerve roots, because most of our rotation and our axial load is placed on the lower lumbar nerve roots. So they tend to degenerate at a much higher rate and faster rate than the higher lumbar spine. Extensive lumbar spinal stenosis typically causes, in addition to the radicular pain, a claudication type picture, where patient experiences cramping in the calves when walking or standing, and it tends to improve with rest. So when we're thinking about a herniated disc, usually the pain will increase when the patient flexes forward, as this puts more pressure and closes off the foramen, and usually is relieved with extension. So these patients may not want to be sitting in the office during the visit because it hurts when they sit for too long of a period of time. As you're getting the history, you're going to see which dermatome is the pain radiating, and you're going to usually correlate that with your imaging to determine what intervention we're going to perform on the patient. As far as whether or not to image, the usual guideline is if a patient has usually more than 6 weeks of pain without red flag symptoms, you can usually wait until that 6-week mark to get imaging, because usually pains less than 6 weeks will improve on their own and will not need further intervention. However, if conservative therapy has failed and 6 weeks have passed, then imaging is usually required to determine what the next step will be. As far as the type of imaging, we usually will require an MRI of the lumbar spine or the cervical spine without contrast, unless you are worried about infection, or if the patient has had a previous surgery where the addition of IV gadolinium may help differentiate different pathologies such as scar tissue or infection. But for the most part, MRI spine without contrast will suffice. CAT scan is useful in differentiating bony pathologies, such as vertebral compression fractures, but usually X-ray alone gives you enough information for bony pathologies. So now you've diagnosed the patient's radicular pain. You might have gotten an MRI or referred to an interventional pain management doctor who ordered the MRI and determined that there might be a herniated disc causing a lumbar radiculopathy. So the treatment sort of algorithm, as you can imagine, starts with conservative therapy, physical therapy, medications, and if the conservative therapy has failed, our usual next step is an interventional injection. So the type of injection we would perform for a radicular pain is an epidural steroid injection. We have three ways of accessing the epidural space for epidural steroid injections. We have the interlaminar technique, the transforaminal technique, and the caudal epidural technique. And I'll go over those on the next few slides. The interlaminar epidural steroid injection is our most common epidural performed. As the name implies, we are introducing the needle in between the lamina. So our injections are image guided with fluoroscopy, and this allows us to introduce the medication at the specific level of the patient's impingement. The advantage of the interlaminar technique is that we can get medication to cover both sides. So if somebody has bilateral radicular symptoms, this may be the technique of choice because we can allow for medication to diffuse bilaterally. We also, as you are aware, are far away from the foramen where the nerve roots are actually coming out. So we have minimal risk of a paresthesia or dysesthesia during the injection or nerve root injury. There's also not a lot of vasculature encountered with the interlaminar technique. And for the cervical spine, it's the only accepted technique to minimize risk of inadvertent vascular injection, especially in the cervical spine. We can also use a type of steroid that has particulate. Most of the pathologies are occurring anterior, where the disc is actually impinging on the nerve root. So with this technique, we're accessing the epidural space in the posterior space. We also risk inadvertently puncturing dura, and this may lead to a post-dural puncture headache. However, with image guidance, this complication is rare. And finally, depending on the level of the epidural, there's risk of spinal cord injury. However, again, this is a very low risk. The second technique of the epidural steroid injection is the transforaminal approach. And again, as the name implies, we are accessing the epidural space at the intervertebral foramen where the nerve roots are coming out from the central canal. So we oblique the X-ray machine towards the side of the pain, and we get what's called a Scotty dog view. If you can imagine the head of the dog, the ear of the dog, the neck of the dog, and the feet and body and other foot of the dog. The head of the dog is our pedicle, and we are targeting just 6 o'clock of the pedicle, above where the nerve root is coming out, but below the bone. When contrast is administered, we want to see contrast entering medially into the epidural space. The advantages of the transforaminal approach are that we can target the specific nerve root with the steroid and the local anesthetic. And we can get more anterior spread, especially if a patient has more of a central disc herniation, to coat that area with the steroid more reliably than the posterior interlaminar approach. The disadvantages are obviously being in close proximity to the nerve root. There is risk of dysesthesia, nerve root injury, spinal artery injury or infarction. But these complications are very rare given our fluoroscopic guidance and the use of contrast. The final technique is the caudal epidural steroid injection, which is done at the terminal coalescence of the spine at the sacral hiatus. And we're able to inject a large volume of medication at the inferior aspect of the sacral spine to coat areas that are inflamed more cephalad. The advantage of this approach is that we can use a thinner, less traumatic needle. We can just do one injection as opposed to the transforaminal, where we may have to cover more than one nerve root. And there's essentially no risk of inadvertent dural puncture with this technique. So in patients who've had previous surgeries, we may choose the caudal epidural technique or the transforaminal technique. In patients who have never had surgeries and have bilateral symptoms, we may choose the interlaminar technique. So that is for radicular type pains. Let's shift focus for patients who are experiencing axial non-radiating pains. The most common cause, in addition to just myofascial or muscle pain, especially in the older adult, is facet joint hypertrophy and arthritis. So this will cause a chronic back or neck pain that is insidious, not an acute onset, as most arthritic pains occur over a long period of time. And it should be completely or predominantly axial and non-radiating. It may be described as a deep, sharp, or aching pain that doesn't radiate in the neck past the shoulders or in the low back past the buttocks or the thighs. And it should not be associated with any neurodeficits because, again, this is an arthritic pain, not a nerve-related pain. The type of pain or vicinity of where they may be experiencing pain is illustrated in this image for the low back and in this image for the neck. As you can see, may radiate some, but shouldn't radiate too far, again, past the shoulders or past the thighs. So the facet joints are true synovial joints that are formed by the superior articulating process of one vertebral body and the inferior articulating process of the one above. There is a dual innervation for these joints with a medial branch nerve from that level and a medial branch nerve from the level below. So these nerves are called the medial branch nerves, and their main function is sensation, providing sensory innervation to the facet joint, with one motor innervation to a non-clinically relevant muscle called a multifidus muscle. So as you can imagine, to determine if pain is coming from the facet joint, what we can do is inject some local anesthetic around these nerves as a test, a diagnostic test, to see if while those nerves are numb, if the patient's pain gets better. If their pain improves for the duration of the numbing medicine, that tells me that the pain is coming from the facet joint. So the injection to numb those nerves is illustrated in this image. We, again, oblique our X-ray to get what we call the Scotty dog view. And the medial branch nerve lives at the junction of the superior articulating process and the transverse process. So we insert a needle into that area and we inject some numbing medication, usually lidocaine or bupivacaine. And the same process can be done in the neck for axial pains of the neck. As you can imagine, with the numbing medicine, the pain should return after about 4 to 6 hours, depending on the type of local anesthetic that we use. But after we've successfully diagnosed the problem, we can do a procedure called a radiofrequency relief. But this is only done after 2 successful diagnostic talks to make sure that the pain is coming from those facet joints. And usually after radiofrequency ablation, we can afford the patient about 6 months to a year of relief before those peripheral nerves regrow. Oftentimes when they regrow, they don't. This procedure can be repeated every 6 months to a year without the need for test injections. So that's facet pain for axial back pain. Now just to briefly talk about vertebral pain, the most common cause of vertebral pain, especially in the older population, especially after a trauma in a patient with osteoporosis, is a vertebral compression fracture. These are not insidious. They're usually acute on onsets, usually after a trauma. But in the setting of osteoporosis, we've even seen patients with very minimal traumas or just a maneuver that they're not used to doing, such as a quick rotation or even opening a window that is difficult to lift, can cause vertebral compression fractures in the elderly population, the older population. Typically, these fractures occur in the thoracic or the upper lumbar spine. It'll be mostly in axial pain. However, if the fracture contents enter the spinal canal, you may get nerve-related pain as well. Or if it's a very severe fracture, you may get signs of myelopathy. So it really depends on the fracture pattern or the severity of the fracture. So on your exam, you may notice midline tenderness to palpation, or with percussion, it may reproduce a severe pain in the midline. Very few things in the spine cause midline pain. Most pains are paravertebral. The final cause of vertebral pain is spondylolysis, and this may occur with a fracture of the pars inticularis. Usually this is in younger patients, but can be seen in the older population as well. And finally, non-spine pain mimickers, fibromyalgia, myofascial pain, and sacroiliac pain. Fibromyalgia is a widespread pain, usually correlating with the American College of Rheumatology diagnostic criteria, and may be associated with fatigue, depression, anxiety, insomnia, etc. Very few injections may be helpful for patients with fibromyalgia. However, medication management is usually indicated for these patients. Myofascial pain, pain related to the muscles, can be treated with interventional techniques as well, especially when conservative therapies fail. So myofascial pain, as you would imagine, is a muscle pain, non-radiating pain that is tender to palpation. And when you're palpating these muscles, you may feel knots in the muscle as you're palpating. What we can do for this type of pain is a trigger point injection to mechanically disrupt the knots to allow for better blood flow through the muscle. And this is a very simple procedure. It can be done with patients on blood thinners without the need to stop the anticoagulation, as opposed to epidural steroid injections for radicular pain, which would require a safe stoppage of the anticoagulation given the risk of bleeding in the neuraxial space. And then the final non-spine pain mimicker is sacroiliac joint pain. This is an axial pain that is usually related to movement. So dynamic movements such as going from sitting to standing or twisting may cause pain in the waistline above the buttocks. You may press on their posterior superior iliac spine, mimicking their pain. And then finally, the physical exam maneuver called Faber, which is where you flex, abduct, and externally rotate the hip, may cause pain in the in the lower back. An injection can be performed not only to help sacroiliac joint pain, but also to help diagnose it as well. So using fluoroscopic guidance, we introduce a needle into the inferior part of the sacroiliac joint, inject contrast to confirm our placement, and then inject a local anesthetic with a steroid to hopefully help their pain. Let's shift gears and talk about various nerve blocks that can be done for cancer pains, for visceral pains, and other sympathetically maintained pains. So with these injections, our first goal is to help diagnose if these nerve bundles are responsible for the patient's chronic visceral type pain. Going from head to toe, the typical type of sympathetic nerve blocks that we perform in the interventional pain management world are the celiac plexus block, the lumbar sympathetic plexus block, superior hypogastric plexus block, and the ganglion impar block. Let's start with the celiac plexus block. The celiac plexus is composed of the greater, lesser, and least splanchnic nerves, where they coalesce anterior to the diaphragm to form the celiac plexus. The location of the plexus is usually at the inferior portion of T12 or and the superior portion of L1, where they coalesce anterior to the crura of the diaphragm. The primary indication for performing a celiac plexus block is to alleviate abdominal visceral type pain. Neurolysis can be performed after a successful diagnostic block where phenol or alcohol can be injected instead of just local anesthetic to ablate those nerves to cause to afford the patient longer lasting relief. But usually a diagnostic block is performed first prior to neurolysis to make sure the patient will improve before a more definitive neurolysis is performed. The celiac plexus block is best used to treat cancer pain anywhere from the distal esophagus to the transverse colon. So any malignancy related from the distal esophagus to the transverse colon causing a visceral type pain that's refractory to conservative therapy may respond to a celiac plexus block. We typically perform this injection for pancreatic cancer pain. Some of the contraindications for celiac plexus block are anticoagulant therapy, patients with an underlying coagulopathy, infection or sepsis, or bowel obstruction due to the increased peristalsis that may come from the local anesthetic effect on the parasympathetic nerves during the injection. So by blocking this nerve plexus, you would expect to get hypotension and actually a brief period of diarrhea because of the unopposed parasympathetic activity after blocking the sympathetics. So you would get vasodilation of the vessels in the legs because of blocking the sympathetic nerves, and the diarrhea related to blocking the sympathetics of the gut. This injection is typically done with CT guidance, given the amount of vascular structures that are in the vicinity of the celiac plexus. So usually with CT guidance, a needle is introduced just lateral to the vertebral body, just lateral to the aorta, anterior to the crura of the diaphragm, where the medication can be administered. The next most commonly performed sympathetic nerve block that is done in the interventional pain management world is called the superior hypogastric plexus block. The superior hypogastric plexus is a retroperitoneal structure that is just lateral of midline, usually the lower third of the L5 vertebral body, and upper third of the sacrovertebral body. This block is indicated for either benign or malignant pains that are affecting the pelvic visceral structures, not including the external pelvic organs. So we're talking colon, rectum, bladder, uterus, some intervaginal pain, prostate, testicular pain, or urethral pain. Complications of this block include intravascular injection, neuraxial injection, inadvertent discal injection with infection, urinary injury, and bladder bowel incontinence. This block can be performed with X-ray guidance, where a needle is introduced just lateral to the L5 vertebral body, just anterior to the lip of the vertebral body, where contrast can be given to ensure that the hypogastric plexus block will be coated with medicine. The next most commonly performed sympathetic block is the lumbar sympathetic block. This is a 4 or 5 paired ganglion, usually at the level of L2 or L3, and is responsible for sympathetically maintained pain in the lower extremities, usually related to CRPS or complex regional pain syndrome, phantom limb pain, some vascular insufficiencies and peripheral arterial disease, Raynaud syndrome, can be performed for acute herpes zoster, can be done for hyperhidrosis, frostbite, or crush injuries. So really any type of sympathetically maintained pain or vascular pain of the lower extremities. Using X-ray guidance, we again introduce a needle just lateral to the L3, top of L3 vertebral body, where contrast is given to ensure anterior spread where the ganglion are located. The side effects or complications of the block include hypotension, again, because you are blocking the sympathetic drive to the vascular structures of the legs, bleeding, infection, inadvertent intravascular injection, less commonly intralymphatic injection, subarachnoid injection, etc. Very low risk given the use of fluoroscopic guidance. The next most common is the ganglion impar block, which is the terminal coalescence of the sympathetic chain in the sacral spine. It lies in front of the sacrococcygeal junction and receives fibers from the lumbar and sacral portions of the sympathetic and parasympathetic nervous systems that innervate the pelvic viscera and genitalia. So where superior hypogastric plexus block was done for internal pelvic organs, the ganglion impar block is done for external pelvic visceral pain or genitalia pain. Usually done for perineal pain, rectal pain, again, genitalia pain, pain related to malignancies of those structures, endometriosis, complex regional pain syndromes, proctalgia fugaz, levator ani syndrome, radiation enteritis, are the most commonly performed indications. Using fluoroscopic guidance, we introduce a needle through the sacrococcygeal space, just anterior, where we coat the nerves with the medication. As you can imagine, bowel sits anterior to this space, so the use of contrast ensures that we are not too anterior into the bowel itself. Side effects or complications include bleeding, nerve injury, puncture of the surrounding organs, including the rectum, or epidural spread, with the low risk of all of these things because of fluoroscopic guidance. The final thing I would want to mention is intrathecal therapies for chronic pain. Research of intrathecal opioids began in the 1970s and was usually, and still is usually, reserved for cancer-related pains. Patients generally need a life expectancy of greater than 3 months for this to be a technique that may be helpful for patients. The patient needs to experience intolerable side effects to a PO opioid regimen and inadequate response, analgesic response to the regimen as well. Evidence of intrathecal opioid use in cancer pain supports improved pain control, with usually about a 20% drop in VAS and decreased drug toxicity given the central administration of the medication in the intrathecal space, rather than relying on a PO medication which will cause unwanted side effects such as sedation, constipation, etc. The FDA-approved medications that can be given intrathecally are morphine, baclofen, and a medication called, pause one sec. Okay. Restart. The FDA-approved medications that can be given intrathecally include morphine, baclofen, or a medication called ziconotide. The usual medications that are given intrathecally via an intrathecal pump are usually an opioid like morphine. So with a reservoir in the anterior abdomen, a catheter traverses the subcutaneous space and enters the intrathecal space where it is threaded more cephalad and can administer medication into the central nervous system. Intrathecal pumps come with a lot of complications and unwanted side effects and are falling out of favor, but remain an option for refractory pain conditions, especially related to malignancies. So we went over what a pain management physician's role in the multidisciplinary team is. We went over the most common causes of neck and low back pain. You'll remember to ask about red flag symptoms where imaging may be required before the 6-week mark. We've gone over various types of injections that can be done to treat chronic neck and back pain or chronic visceral or cancer-related pain in patients with chronic refractory pains. And we've gone over nerve blocks for refractory cancer pains that may be helpful. Let's conclude with a CME-related question in terms of an interventional pain management technique. We have a 72-year-old woman with metastatic pancreatic cancer who's experiencing severe abdominal pain, not responsive to a multimodal analgesic regimen, including high-dose opioids. Her oncologist refers her to an interventional pain management doctor to consider a celiac plexus block as part of the pain management plan. Which of the following statements about the celiac plexus block is accurate? A, it is primarily used to manage pain from osteoarthritis in older adults. B, the procedure is associated with a high risk of causing significant hypertension due to a sympathetic nerve blockade. C, it should be avoided in patients with diabetes due to a high risk of exacerbating hyperglycemia. D, celiac plexus block is indicated for the management of pain related to cancers from the distal esophagus to the transverse colon. Or E, the procedure involves injection of local anesthetic directly into the spinal canal. The correct answer is D. Celiac plexus block is indicated for management of pain related to malignancies that originate from the distal esophagus to the transverse colon, including the pancreas. Celiac plexus block, as we discussed prior, is a well-established technique used to manage abdominal pain, particularly in cases of pancreatic cancer, where pain control is challenging using other techniques such as medications. Procedure involves injection of anesthetic or neurolytic agents around the celiac plexus to disrupt the pain transmission from the abdominal organs, from the distal esophagus to the transverse colon. It is not commonly used for osteoarthritis, where we would usually do a joint injection for those types of pains. Would be related to hypotension rather than hypertension, given the blockade of the sympathetic innervation to the vessels of the lower extremities, causing vasodilation and hypotension. Diabetes is not a contraindication, given the fact that the initial blockade is just with a local anesthetic, and a more permanent relief is done with a neurolytic agent such as phenol or alcohol rather than steroid. If steroid is used, the usual increase in finger stick glucose is temporary for usually about 5 days to 7 days, and with monitoring does not usually cause sequelae. The procedure is performed percutaneously rather than intrathecally, with care to avoid any intrathecal structures, as we are just lateral to those structures, to advance the needle just anterior to the aorta, anterior to the crura of the diaphragm, where the medication is injected around the plexus itself. So overall, celiac plexus block is a valuable technique in managing severe abdominal pain from pancreatic cancer and offers significant pain relief by targeting the celiac plexus nerves. Thank you for your time, and I hope I was able to shed some more light on interventional pain techniques for caring for chronic pains in the geriatric population.